to myectomy. Professor Kramer.
Thanks, Magdi. So, Dr. Moharram discussed early HCM, identifying preclinical HCM. I'm going to focus more on the overt disease. These are my disclosures. So I'm going to be focusing on both echo and CMR. Echo is useful for screening, identifying the disease, measuring the ejection fraction, the gradient in the outflow tract in obstructive HCM, assessing mitral regurgitation, and we use it all the time now to assess the safety of mavacamten and now soon to be aficamten, the new cardiac myosin inhibitors. For CMR, we use it as the best method for assessing the morphology of HCM, best method for identifying the wall thickness, and most importantly, identifying scar as a risk factor for sudden cardiac death. We do use CTA selectively in HCM and HCM patients with anginal chest pain to exclude coronary artery disease. So first of all, how do we define overt HCM? It's defined as unexplained hypertrophy, so no underlying cause. In the past, we used 15 millimeters as a strict cutoff with two exceptions. One, if a patient has a clear genetic sarcomere mutation underlying, we use 13 millimeters, and the apex can be thinner than the base, and so we don't use 15 millimeter cutoff in the apex. But there was this recent paper in JACC that our group was involved with as well, led by James Moon's group, that showed that wall thickness really needs to be corrected, similar to calcium scores, age, gender, and in this instance, body surface area, so that we are identifying smaller women with HCM as compared to obese older men. So really there's a calculator online, hcmcalculator.com, that can help identify patients with HCM with wall thicknesses less than 15. So we used to say HCM is a disease of 1 in 500 individuals, but with more advanced use of advanced imaging and genetic testing, we're recognizing that's probably higher incidence, 1 to 200 or 300. It's the most common genetic heart disease. There are really two types. One is about 40% have the sarcomere mutation. The other 60% have a polygenic risk, and you superimpose obesity and hypertension, and you get asymmetric hypertrophy. And it's the #1 cause of sudden death in young athletes. As Dr. Moharram mentioned, the pathology is one of myofibrillar disarray, interstitial fibrosis compared to a normal on the right. And here's a typical 4-chamber long axis view in a patient with reverse septal curvature morphology compared to a normal on the right. So we used to, this is an older slide that suggests that 2/3 of patients with HCM are obstructive, that about 41% have a rest gradient more than 30, and then another nearly 30% have a provocable gradient, either with Valsalva or exercise echo of more than 30. And then the other non-obstructive subtypes, about 1/3 of patients. But with more use of advanced imaging, better diagnostic capabilities with echo, it's my hypothesis, I don't think this has been proven in a paper now, that there is more non-obstructive disease out there, because 20 and 30 years ago, the only patients we were identifying were patients with obstruction. And so now I would say it's about 50-50 in terms of percentage of obstruction versus non-obstruction. Here's a typical echo in a patient with massive septal hypertrophy at end diastole and end systole. Notice the anterior leaflet of the mitral valve hitting the septum. Here's a patient with apical HCM shown in a 4-chamber view. It's quite important to use contrast in patients with suboptimal windows to better identify patients with apical HCM, because it can be missed by echo, and that's an important application of CMR. The other important use of echo is to identify chordal anterior motion, SAM, septal anterior motion. In this case, in this 5-chamber long axis, you see the cords abutting the septum. You can see it on M mode. This SAM leads to LVOT obstruction that's dynamic and load dependent. You see premature closure of the aortic valve and distortion of the mitral valve. As the anterior leaflet is pulled towards the septum, there can be quite often in the patients with LV outflow tract obstruction the so-called V sign with a perpendicular jet, posteriorly directed jet of mitral regurgitation. At the same time, you see the systolic turbulence in the LV outflow tract. It's important to use continuous wave Doppler to assess the gradient, both at rest and with either Valsalva or stress provocation. Again, 30 millimeters of mercury is used as a cutoff. And it's very important to differentiate MR from intracavitary obstruction to train your technologists to do that. Here's an example of the dagger-shaped gradient envelope with continuous wave Doppler at rest with Valsalva, amyl nitrate, which we no longer use. But here is an example, again, dagger-shaped, late peaking gradient envelope, very different from the holosystolic rounded envelope of mitral regurgitation. It's important for your technologist to scan across the mitral annulus to differentiate mitral regurgitation from SAM and LVOT obstruction. So turning now to the use of CMR, here's a patient with the reverse septal curvature morphology as well as apical HCM, unusual morphology. CMR is the gold standard for LV mass and volumes, assessing morphology. We can certainly use CMR to measure an outflow tract gradient and mitral regurgitation, but that's done quite well with echo, so that's not the reason to do CMR. One of the reasons to do CMR, in addition to accurately measuring wall thickness, is to assess the morphology. These are images, 6 examples from our paper in JACC in 2019 from the hypertrophic cardiomyopathy registry that Stefan Neubauer and I run, 2,750 patients recruited from 44 sites in North America and Europe. And the final outcome results are now in review at JAMA. This is data from our baseline paper. About 45% of patients had isolated basal septal hypertrophy. Another 40% or so had reverse septal curvature morphology. This patient also had an apical aneurysm. 8% had apical HCM. 1% had concentric HCM. 3% had the high-risk, interesting subtype of mid-ventricular cavity obstruction with an apical aneurysm. And another, this is actually my patient, 1% of patients we termed other. They didn't fit in any of the other 5 categories. And this patient has isolated lateral wall hypertrophy. But most importantly, the use of CMR is to identify scar. So these are 6 different patients. Patient A has no scar. Patient B has confluent scar in the anterior wall. You might think it's an infarction, but there's subendocardial sparing, which is not seen in MI. Patient C has the classic form of LGE and HCM at the RV insertion sites, which is probably the most common manifestation. Patient F has massive septal hypertrophy and this diffuse, fluffy LGE in the septum. Turns out we see LGE in about 50 to 60% of patients. In HCMR, it was exactly 50%. So you can't use the presence of LGE as a marker for an ICD because the incidence of sudden cardiac death is quite low these days, about around 0.4% per year. So if you put an ICD in half the patients, you're putting way too many ICDs. So the presence of scar is not the key finding, but it's certainly a marker of adverse prognosis. This meta-analysis of over 3,000 patients showed that the presence of scar is associated with a 1.8-fold increase in all-cause mortality, a 3-fold increase in cardiac death, an over 3-fold increase in sudden cardiac death, and an over 2-fold increase in heart failure death. But more importantly than the presence of LGE is the extent of LGE. And this was shown in this paper by Chan and colleagues from Marty Marin's group. 4 tertiary care centers, high-risk subgroup with a higher than average incidence of sudden cardiac death. But what this group showed is that once your late gadolinium enhancement was more than 15%, the incidence of sudden cardiac death doubled. So you can see the stepwise increase in sudden cardiac death as you increase the extent of late gadolinium enhancement. And the cutoff used in the 2024 U.S. guidelines is 15% of left ventricular mass because of this paper, and also this paper from the Cleveland Clinic that shows, again, that there are increased events in the green bars in either obstruction or non-obstructive patients once their LG is over 15%. But is 15% the right cutoff? Probably not. It's probably too high. This is a Chinese study. Maroon bars represent sudden cardiac death events. You can see that most of the events are those with LG more than 15%, but there are a substantial number of events in patients with between 5 and 15% LGE. In fact, this meta-analysis in JACC Imaging a year or so ago showed that the optimal sensitivity and specificity to predict sudden cardiac death is probably closer to 10% of LV mass. So just a couple of words about hypertrophic cardiomyopathy registry. We started recruiting patients in 2014 through 2017. We're at a mean follow-up of 7 years, and as I mentioned, the outcome data is in review at JAMA. I will say that CMR is extremely important at predicting outcome and sudden cardiac death in HCM. So this is findings from our baseline paper in JACC. 85% of the patients we could put into two relatively distinct populations. About 40% were sarcomere mutation positive. They tended to have reverse septal curvature morphology and they were the patients with extensive late gadolinium enhancement. As well as because their hypertrophy was in the mid-septum, not the base, they tended not to have outflow tract obstruction. Another 45% or so of patients had isolated basal septal hypertrophy. They were sarcomere mutation negative. They have the polygenic form, and they tended not to have any late gadolinium enhancement or interstitial fibrosis. And because their hypertrophy is at the base, these are the patients have more LVOT obstruction. So as we follow these patients, are the patients on the left, the ones at risk for sudden death, and the ones at the right, higher risk for heart failure and need for cardiac myosin inhibition. In terms of indications for ICDs, this is the 2024 ACC/AHA guidelines. 4 of the indications are identified by CMR, including massive LVH, defined as wall thickness more than 30, LV apical aneurysm, end-stage HCM defined as an EF less than 50%. These are all 2A indications for an ICD. And then extensive LGE on CMR is also a 2B indication for ICD. One other use of CMR, and I was involved in these studies with both mavacamten and aficamten, showing reverse remodeling with cardiac myosin inhibitors. For the first time, medications that reduce left ventricular mass index, and this was over 18 weeks, reduces LV wall thickness, reduces left atrial volume without a change in late gadolinium enhancement. And the same was true in this paper, for which I was senior author, with aficamten. The previous paper was with mavacamten. So reduced LV mass, wall thickness, and left atrial volume. So in summary, echo is quite useful in HCM for identifying patients, measuring the gradient, measuring MR, following patients on CMIs, but CMR is crucial for identifying morphology, wall thickness, as well as scar for identifying prognosis in HCM. And with that, I'll end, and thank you for your attention.
Thank you.